Did you find it interesting yesterday when Ed Banos talked in his first talk, and he talked about he had a waiting list for RNs? Does anybody else have a waiting list for RNs? That's probably the first time I've heard that, and I don't even know how long. So this is what we're going to talk about of managing and what can you do. I'm going to go over some data. I'm actually then going to go into a nurse extender program, and then I'm going to even go into how can you finance it. So you'll be able to take this back to your senior leaders if this is something you think that would interest you. So we're going to, as I said, look at the nurse statistics, and it's kind of interesting. When I went back and looked at the nursing workforce report, the latest one, what they said on nursing shortage and where we're going with that. And then also, as I said, about the RN extenders. This is something that when I was with HCA, so I was a division vice president along with two other division vice presidents. We worked on this, and so we're going to talk about this and see if it's right for you, and then how do you implement this type of an alternative model. Because as I said earlier, you got to sell this to your C-suite. So let's look at some of these statistics where they're at. So right now, the nurse workforce report is saying that RNs and nurses across the board are the largest group of healthcare providers who's are in need. So from that standpoint, nurses are directly linked to quality and cost effectiveness. So if you do not have enough nurses in your department, you will oftentimes, this will be an outcome of that, is the quality and cost effectiveness of that. They're also projected to grow 7%, which is the largest from 2019 to 2029. So of all occupations across the country. And then this is really interesting because I fall into this, or already fell into this, but 10,000 people each day will turn 65 until 2030. So in this report, they actually now go to 2035. So we're going to see some interesting data from that perspective. So from 2020 to 2035, part of what they're looking at is we don't know the impact on the nursing workforce quite yet from COVID-19. And we had a lot of early retirements. People changed careers, as some of the speakers have already talked about this morning. Burnout for in emergency medicine is really huge. And what is that going to do between now and 2030? And then nurse practitioners, nurse anesthetists, and nursing midwives nationally will have a surplus in 2035. Is that not interesting? Because we have, for the last decade, talked about the nursing need and how shortage we're going to have. So this is some of the projected from 2025 to 2035. So in 2025, this is the shortage that we're going to have for registered nurses. And so over 78,000. Then in 2030, that drops to 63,000. And then interestingly enough, 2035, we're going to have an excess of RNs in the country. So, but this, I will say, this is a national average, and this is what they're projecting nationally. However, I'm going to show a couple slides on geographically. That's not going to be true in all states. There's a big variance there from a surplus in North Dakota of 48% to a shortage in the Washington state of 26%. So very interesting. It looks good on paper, but you have to then go down into your state and then into your local area. Because they're projecting within the urban areas, there will be excess of nursing. It's then again, what are you doing in the rural areas and smaller ERs and hospitals where that will be. Then for your LVNs and LPNs, again, the same thing you look at follows the RNs where you have a shortage in 2025 and 2030, and that is actually supposed to say an excess in 2035. And again, that variance is very much the same of a surplus within Arkansas of over 50% and a shortage in Alaska of 88%. That's going to be tough if you're in Alaska. So what states in 2035 are projected to have the largest nursing shortage? So I've listed the states here. I did this talk probably about 5 years ago, and it was very interesting to do a comparison between then and what they're projecting now. So it's again, how do we deal with that? How do we deal that as nurse leaders and as hospital leaders? It's something that you just cannot ignore, and it's not something you can say this is just the way it is. We have to come up with creative solutions to this. This is the salaries. I put this in because we're going to do a little financial exercise here in a few minutes. So you can see, look at the variance across the country, and I was actually surprised of these, that Florida was as low as it is compared to some of the other states. So it's, again, the average comes out of these 5 states of $45 an hour. So what are we going to do? I really recommend, how many of you are doing team nursing now? A few hands. So I do think that it is time for both RN extenders to look at care team models, and we're also going to talk about how do you pay for an RN extender. And you're probably saying, what is an extender? Well, we came out, I don't know, what docs in the room, what was it, in the 80s, late 70s, 80s, with the physician extenders. And I have had the honor of having very good extenders during my career, physician extenders. But I think it is time to look at RN extenders. RNs right now are doing way too many tasks. That is not what a registered nurse is supposed to do. We're supposed to have our LVNs do that, and other care team members, that they do a lot of the tasks for us. There are tasks that only an RN can do, and that varies from state to state, but they're very similar. So really, let's go back to what the RN is supposed to be doing. So first of all, let's talk about team nursing. What that does is it brings the RN back and really maximizes the skill set of that registered nurse. The RN gets work done through delegation to other team members. And then they have increased care team satisfaction. I will tell you, when this is implemented correctly, the staff satisfaction goes up. And I have always been a leader that firmly believes if you have good staff satisfaction, guess who else has good satisfaction? Your patients. So focus on making a better work environment for your team. And then, as I said, increase patient, and then it decreases your staff turnover. This is a lot of what Ed was doing. I know enough about Ed's hospital. They worked very hard on creating a very good work environment. And now what does he have? He has RNs, not just RNs, it's other healthcare workers wanting to work, because the culture there is about having a good workforce environment. Disadvantages to doing a care team model, and you need to be aware of what these are, because if you choose to create this, or if you have one and maybe it's not working the way you would like it to work, is that if it's not implemented and monitored, this is the key here, is you have to monitor how this is going, especially the first 2 to 3 years of this, is patients can get fragmented care. And that's then again where patient safety comes into play here. So I've seen this. We've all had these staff members, right? That whether it's a nurse or a tech, but let's say it's the nurse, the RN on the team that's over that team, is that they sit back and say, well, that's his task that the tech can do, so I'm not going to do it. The tech is running around just like crazy, and the nurse is sitting back drinking her coffee, and that. So we have that. But then on the other hand, we have techs that what? Disappear for hours. We have no idea where they are, and I'm working very hard. It's very critical to patient safety that I need to get to my next patient, but I have to do this task that tech has disappeared for. So it is something as leadership you need to teach your team about the importance of everybody being a team and how to be a team and how to share that responsibility. But accountability is very clear, and it takes a lot of time from the department leadership, and this includes our physician partners leadership, because physicians a lot of times, we just talked about the new physicians coming in. If they have not been, or the older physicians haven't been in a care team model, when I started nursing, guess what? In the ER, we did a lot of the care team model. And it just worked. And I was never taught it and just went into it, and that's how it was. But we've lost that over the decades. So the other thing that can come up about this is confusion. So if we don't align and communicate well with each other, so you have to teach your nurses good communication skills of how to delegate. And I'm going to go over a delegation slide here in a little bit. But if they don't know how to set expectations to a tech to say, I need you to do this, But as we said just earlier, did they get a communication back? Does that conflict with something that's already been given to them? This is why a care team model is we don't share techs in this. And what we do is that tech reports to a RN. And thus, there shouldn't be confusion. Right now, a lot of times with our techs, you have nurse A, nurse B, and nurse C all telling that tech to do something, and they have competing priorities. So look at that so that you can reduce that confusion. And then the accountability. Teach each other how to talk to each other, and it be in a positive way to increase your accountability. Because that is probably one of the hardest things for a lot of caregivers to do, is within the team, is how to give that feedback so that people can improve that accountability and set expectations. But then have a chain of command, and as a leader, if I have a nurse that's leading a team and who's having a hard time, or there's a team member on that feels that nurse isn't doing there, have a method for them to communicate back to you so you can do education to get people around, because this takes a good 2 years to get it into a culture of bringing that along. This is a care team model that we tend to see now. We have the physician, and then you have your charge nurse leader that is kind of has a dotted line to the physician along with the APP. And then you have all your RNs, and these are kind of the rooms that they have. So you have, the physician that's over like these 18 patients or rooms. And then each nurse has, 5 to 6 patients, and they have extenders that may help them and may not. But this is one of the things that I would like to see us get to. I'm going to do a little bit more a little later on to go out what this could look like from a standpoint of that. So implementing a nurse extender program. So we really want to talk about, do you need it? When do you need it? Why do you need it? Who is your extenders going to be? And that is one of probably the most important questions you need to have in your mind of what that can be. And then how are you going to implement it? And then when will you implement it? So first of all, one of the most important things you need to do, when we did this, the 3 VPs and we got together, we were going across 4 state lines. And the variability of looking at this from a state board of nursing rule, but you not only need to know that, if you're going to use paramedics, you need to understand their state regulations and what they can do. One of the things about paramedics, I will say, is this, is not every state of our 4 states could do that, because a paramedic oftentimes can only report to a physician. And if that is true, what occurs? That paramedic becomes a physician extender and not a nurse extender. So you want to be able to pay attention to that and know what that is. That may be a rate limiting step in your state to put a paramedic in. The next ones are your LVN and LPNs. I personally prefer those. They've been taught the nursing process. They understand that. And then techs. And you can have different levels of techs, but most of the time you're going to have to do the training within your department to have the techs do the tasks that you want. And a lot of states allow that if you have competencies and training that you can show, these techs patient care techs can go up to a higher level to do the tasks that you need as an RN. Buy-in. Buy-in from your executive team is extremely important. The CFO, I would start with. Go to the CFO and understand for what would they want for you to put this into place. Your CNO is very important very early on to let them know and communicate to them, I'm going to look at this program, I'm going to be working on it. Is there anything that you see? What would your concerns be? So you address those up front when you're ready to present this program to you. And then know what the extenders are. Say that you can do paramedics, but you have a shortage of paramedics within your community, then do you really want to go down that road? But look at that and see what would that be. Geographic care teams, I'm a fan of geographic care teams, but there are some limitations to these. Sometimes your geographic footprint of the ER doesn't necessarily make that a really viable option. Sometimes you can do partial geographic care teams, but I do strongly recommend that you go back and look at that. There are no bed assignments to a geographic care team, okay? That means that as a nurse, I don't have beds 1, 3, 1, 2, and 3, say. I have a location, a pod that I'm assigned to. So you want to look at this layout. You want to think about your critical care and trauma areas. How will you do that? Some places kind of leave that a little bit separate, and I'll show you in my example of how I would do this at a mid-level ER. And your arrival patterns and what is your low acuity. You know, what is the volume and how do you do this? And sometimes it's easier, then you look at opening pods, if you will, and closing pods together. So your staffing becomes a little bit more aligned and a little bit easier because it's much more on a geographic care team standpoint. So we're going to use this kind of as an example going forward from here. So we're going to look at this 30-bed ER. It's a community ER. It has 17 beds in the main ED. They have 2 critical care code rooms. They have 15 other rooms. And then they have room 17, you know what, that's hardly ever used because guess what? I don't have the staffing to open that. There are low acuity areas, 6 beds. 6 beds tend not to be used in that low acuity area because, again, of staffing. The CDU overflow area is 7 beds. So this is kind of a map of just a standard footprint of an ER, and you can kind of see how that is. I can very easily see that there could be some pods that we could do within this footprint. Traditional staffing assumptions. Now we're going to go into a lot of assumptions, and here, this is where you can start to fill your numbers in, and you can start to say, does this make sense or not? So this mid-sized ED sees 42K annual visits with 115 patients per day. They do a 1-to-4 ratio, and this is how their 1-to-4 ratio breaks down. They do a 1-to-2 for a critical care area, 1-to-4 in the main ED, and then in the low acuity area, they do 1-to-6. So they have a 2.9 budgeted worked hours per patient unit of service, which is 334 nursing hours per day. And we're assuming that every shift is a 12-hour shift. So this is their current staffing model. So they currently have 2 charge nurses, 1 each shift, 2 triage nurses, 1 each shift. So you have your hours per day, you have how many people per day. And then your RNs is 11 nurses in the main area, and then 132 with, well, this is the whole department. So 4 techs for the whole department. So you think about 30 beds with 4 techs, 11 nurses, not counting your charge nurses. Those techs are pulled in a lot of different ways. Unit clerks, you have 1 per shift, and then so you have a total of 252 care hours per day with 21 people per day. Now, if you go back, they had a budgeted 334. So that's a pretty significant difference there. And why is that? It's because they cannot hire the nurses. And you think about all the beds that we're closing because they do not have the nurses to staff those. Do many of you close beds because of your staffing? People, yeah. And so it's again, you have to think about the impact of that. So our traditional staffing assumptions with this is, whoops, I went the wrong way. So this is the main ED, their current staffing. As you can see in those beds, those 17 beds, but we're not using room 17 most days, is you have 2 techs to do this. And then you break down your nursing assignments there. And so you have a total of 10 nurses in the main per day, and then 2 techs. But there's actually 1 tech, if you think about it, 1 tech per shift to do those. This then is the front end. So it's your intake and your low acuity, and this is how this is. So you have your room assignments, and then you have your techs within there. So now we're going to talk about the nurse extender role and what can that mean. So you really have to understand what is that scope going to be, what's the skill mix, and how to delegate. So the care team roles here is going to be the RN. Now I'm not talking about the charge nurse. The RN is going to manage the care for the patients that are within her geographic area. She or he, sorry about that. They have to do initial assessment by nursing. That is true against every board of nursing role I've looked at. They can delegate appropriate tasks, and then they do the discharge teaching. The extender is the task doer. And this is very important. You want to have them, you want to train them and give them the competencies to go to their full scope. That is how it's going to help you as a nurse the best. And then the care team can or cannot include a provider. It depends on your layout, it depends on the staffing of the providers, but I'm not going to go into that. I prefer that, and I think by our last talk that these new docs coming in, they prefer that. But then again, your team is going to consist of a nurse, 1 to 2 extenders to start with, and you would go to 2 to 3 extenders depending on your area. This is what the new schedule would look like. So within these areas, you can see the rooms have been assigned, and in the main ER that hasn't changed, but look at the tech side. We have increased them from 2 techs to 4 techs in the main, or 6 techs within the main ED. So additional 4 techs a day. And then in the triage area, we've added an additional 2 techs. But guess what? Now we're opening up rooms. Rooms that were closed, we're opening them up. This is the new model of what it would look like, and this is just from a nursing. So you have your charge nurse, you have then your different teams, and I just listed those out, and then you have how many extenders and RNs there. With the critical care area, the 1 nurse that is there, becomes a float nurse. If they do not have patients in their 2 beds, they then float out to help. Or if they have less acute patients, because we don't want to keep beds open, they then can float out and help. So this is the comparison of the old model versus the new model. So our only additional staffing to this is by adding 6 techs or nurse extenders a day from that standpoint. And if you look, we're still coming up under our scheduled numbers, but we're opening up 7 different additional beds. And so from here, we're going to look at your CNO. I've talked about that. You've increased your beds by 7. This does not include any additional provider costs that may be in this to open up those additional beds. This is from the state of Texas. This is, you can go on their website, you can find this. They're very clear on delegation. I will tell you this, if you're to do this, you have to train to delegation. Many nurses and many ER providers have not worked in a system where they understand the rules by the state that you live in of who can be delegated to and what they can be delegated. I recommend in doing an education to the providers and then annual competencies to the nurse based on your state. So we're going to finance this. It's all about the bottom line. So what you want to do is look at your data. What is your RN vacancy rate? What is your turnover rate? How long does it take the time to fill that position? Because we can have positions, you know, it used to be, oh, I'll give you positions, but I can't even fill the 10 open positions I have. So giving me 20 more positions doesn't make a difference, you know? So if it's taken a year or 2 to fill those, this is then when you start looking at creative models to do that. How much money do you spend annually on agency and travelers? What is your staff and patient satisfaction scores? What is your left before treatment completion rates? Understand that. So here we're going to talk about the extender. I went into using paramedics on this for salary dollars. I looked at the annual cost. So this is what it would be to get those additional ones. And then the extenders would cost us an additional, basically $500,000 a year. So that sounds like a lot, correct? But let's look at some financial assumptions here. So we're opening up additional 7 beds. The assumption is we're only going to open those for 12 hours, though. Remember, they were kind of closed, but we're going to now open them for 12 hours because that's our volume needs. And we're going to say we're going to see 3 patients a day in each of those beds. Fair enough? Then we're going to say, okay, that means that 7,600 additional patients annually. Know what your average charge is for an ED visit. I plugged in 1,200. That's kind of what I saw out there in the literature currently. And that means that that's $1,200 times that 7,600. That then gives us, I'm sorry, it's very hard for me to read this, 9.2 million additional revenue. Then the next one is we're going to look at our left without being seen and left before treatment. We're going to then say 8 a day. Is that fair? Most of you see 8 a day? Probably see more. Do a conservative numbers here, like I did. The AAEM said 10%, now this is 2022 data, 10%, and EDBA said 7% across all modalities of all sizes of ERs. So then you look at that and you take the same $1,200 and then say you have an additional 2,900 patients annually. You then put that out, that's another 1.8 million. If you could capture another 8 patients a day, wouldn't that be great? Now, the next one from a revenue standpoint we're going to look at is what is your traveler cost? Because this is something, we talked about this yesterday, something that people really want to get rid of. So from that standpoint, you look at that. Say you have 5 travelers every day. That's not an unusual number that we see within the ERs. Many ERs have many, many more than that. Let's say they do $42 an hour. Remember, I went back to the average cost of that. And so if I could bring in nurses, 5 nurses at $42 an hour that are off of that, I can then bring in, it's a savings of the 920,000. Reduced RN turnover. What is your turnover? So let's say we have a turnover of 5 nurses, $42 an hour, that's another money there. So that we have an additional potential revenue increase of 12 million. Then we take away the salary difference. Remember the $500,000 from before, and then we have additional of 11.5 million annually. If you can present this in such a way to your senior team, do you see how that they would be buying into this? Now, I kept this is pretty FTE neutral from a standpoint of that, because all I did is take positions that were already open to that, because many of our ERs have that. However, when I implemented this, I actually added FTEs. And the FTEs, I had to have buy-in from the CFO. And the CFO at the division level bought into this and thought it was great. He was very happy to see that I could bring him, $10 million more annually. And so it made very much sense to him. Now, where my biggest area and where you're going to have time is with your CNO. The CNO has to buy into this. Where this becomes a difficult thing is if you're on the journey to magnet, or if you already are a magnet. There is often a misperception by our nursing leaders in an organization that magnet says you should have 100% RNs. Magnet does not say that. I don't know what the current number, I think the last time I looked at it, it was around 20% non-licensed RNs could be in an organization. So understand that number and be prepared for that argument and be able to show that. Now, they may have, 20% someplace else in the organization, but again, from a magnet standpoint, this can become a sticking point. So be aware of that, be prepared to talk to that. So again, know your information, know your data, know why you can't recruit your nurses within your community. Is it a community one, or is it the culture of your organization, and what do you do to that? Look at your state board of nursing. Again, you've got to know that up front. That would be one of the first things I would look at. Be proactive in solving your solution and your shortage, because you know what, this may not work for you, but look at creative ways of doing it. I have said for years now, in the emergency department, we have to be creative. We have got to look outside the traditional staffing model. We have to look beyond the 4-to-1 ratio. And this will improve your work environment. This will improve our patients' outcome. And again, get the executive team buy-in very early on. And so with that, I will end, and if we'll take questions at the next section.